going to look at hip complex and the groin. So obviously the first thing we want to do is visually, a bit of a postural assessment. We want to look at the anterior portion. So we look at the iliac crest, make sure everything is relatively in line there. We look for any lumps or bumps initially, which could indicate there is obviously soft tissue damage, any scarring in the area, any bruising. Obviously Will's got a couple of abrasions, just minor abrasions. The ground's getting a little bit harder, so that would indicate, obviously, you know, coming into contact with the ground can cause those types of issues. Just turn to face the wall there for me. So in a standing position, observationally, we want to work through right the way down, alignment of scap, down through thoracic, down onto the lower attachments of the lumbosacral fascia. Want to have a little palpate through again, just stabilising and palpate through, making sure there's no significant pain or anything like that. Hands on the front of your legs for you, Will. Just run your hands down the front of your legs into flexion. Any movement, any pain there at all?
No.
Okay, nice and steady, come back up for me. Again, we just pick up a little abrasion there, a little bit of scarring, nothing too significant. So we want to work through initially a stork test, so up onto your right leg for me. Perfect. We just stabilise and you're coming back into extension. Perfect, and back down for me. And then bilaterally, obviously, we work the other side. And again, making sure we've got stability. We're palpating through the PSIS and then come back through for me. On one leg, so onto your left, magic, and then to extension. Ability to maintain position, obviously, in that single leg stance is important, and then relax for me. Okay, and then we just have a little palpate through and round, make sure we've got the iliac crest again, we've got good alignments. We could also run through, a Trendelenburg test as well, which would be to stabilise PSIS. Well, so I say stabilise, to palpate, and then just bring your right leg up in front of yourself. Magic, bend your knee, that's perfect, and then back down, and the opposite side. And what we would be looking for is any drop on the supported side, which would indicate that a possible glute weakness or hip instability. Okay, magic. So we just check active range, so we can do it in a standing position. So we can just bring the leg into flexion out in front of yourself, and then back through into extension. Again, just checking, obviously you've got a little bit of forward lean there, and then back through. We'd spin around and we work through the opposite side. Okay, so that's flexion into extension. I'm just having a look there. Okay, that's fine. And then turn and face the camera if you would to abduction, and then bring it across into AD. So that's active. Now passively, done slightly differently. So we have Will in a supine position again. Again, just noting any scarring, any significant deficiencies in muscle bulk, that kind of thing. So the first thing we want to have a little look at is we're taking the leg into flexion. So bring it up in front of yourself, a nice straight leg raise. Okay, some signs that there may be a little bit of hamstring tightness is if the knee flexors or the contralateral leg does start to raise up or the quadriceps start to contract. Okay, and then opposite side for me. Okay, a little bit of difference in terms of your straight leg raise. That can also be a test which can be performed to indicate any neurological issues, maybe sciatica if present. Okay, and relax. Okay, so if the pain goes beyond the knee with that straight leg raise, that's indicative of stretching the dura mater, which means that it could be a nerve issue, maybe even a herniated disc. So that is your flexion, and then we take it into abduction, passive AB, stabilising and across, and again bilaterally from the opposite side. We're stabilising the contralateral side, and we're taking that again into abduction. For adduction, we can either come into a slight bit of flexion and then across, or we can bend and take this one underneath, and then we can stabilise and then coming across a little bit further. Okay, perfect. Now for your internal external rotations, we've taken the hip into flexion. For internal rotation, it is the knee aspect, it is the hip, the femur, and we're rotating in. Okay, the foot actually comes out. That's your internal rotation. To your external rotation. Two really important measurements that you want to have a little look at. They can obviously, if painful in any of those movements, can indicate maybe a snapping hip or any labral pathologies or anything that could possibly be going on with the actual glenoid labrum itself. Okay, so with that then, we've done flexion extension, internal external rotation, passive extension, just flip onto your front for me. Reverse straight leg raise, so stabilize sacrum. There we go. So passively we want to support the knee, just nice and easy, just relax that again for me. So support the sacrum, take it into extension, opposite side again, nice and relaxed, take it into extension. Okay, we can also check firing pattern there as well for lower back extensors, glutes and hamstrings, again just through palpation through that reverse straight leg raise. Okay, so from that position then we can again work through stabilizing and coming across into external rotation or internal rotation. We could also work through our resisted with those movements, so we'll just bring your foot back towards midline for me and resist there, and then that is your external, and then your internal rotation, resist outwards. Okay, so the first types of tests now that we want to provoke or bring in identification of the sacroiliac, sacrolumbar region. We can apply and we can palpate a little bit of pressure through the SI joint. We can come across then into the glute complex, coming round into the lateral, have a little palpation through into the greater trochanter. We can then track down IT band from tensor fasciae latae near the greater trochanter to identify any tightness there. To confirm or to rule out any IT band issues, just go on your right side, please, Will, face the camera. Okay, so what we want to do, we want to do Ubers. Now Ubers will determine if we've got any issues, tightness. So we take it into end range extension. If there is IT tightness, okay, then there will be a significant gap between the knees. We could also have a little bit of abduction there as well. So stabilizing lateral complex around the iliac crest. And through a little bit of tightness, nothing massively, and again obviously we'll flip them over and we'll do an objective marker. So from that position, if there was any pain, palpation, maybe through a greater trochanter issue, maybe a snapping hip through greater trochanter, any pain, any popping sensation, that would indicate that we've got a greater trochanter pathology or an issue there. Let's get him onto his back. So if you flip onto your back now, and what I want you to do, I'm going to test for, it's called Gainsland's. So Gainsland's again, provoking SI joint. So we're getting Will over, so his right leg in this case is perfect. I'm going to stabilize pelvis, take the knee into flexion and range, and then you're going to drop that. Stabilize, make sure you're supporting at all times, and any pain there would be on the contralateral or the hip flex side. That could indicate that we have got a possible SI or moving around anteriorly into pubis symphysis, or even through a possible identification of osteitis pubis. Okay, so there's your first. So that's Gainsland's. So what we want then, we want to do a lateral compression test. Again, we're going to try to compress the pelvis together, indicate any SI joint dysfunction, also any possible pain through pubic symphysis, pubic ramus. Again, if we palpate through and around, we've got ASIS, which is the anterior inferior iliac spine, or the ASIS, which is the anterior superior iliac spine, attachments for your rectus femoris or obviously your psoas muscles. With that particular area, we want to have a little palpate through, round into the groin area. Any pain, any issues would obviously be indicative of those conditions. We can also come across and we can apply pressure directly down, making sure we're directly in line, and apply a little bit of pressure through for a shear. We could also run through a femoral shear test. So we take the knee into flexion, the pressure is on the longitudinal axis of the femur, and we're applying pressure down through a controlled movement. We don't want to bounce through, we want to be nice and controlled because obviously we're trying to provoke pain. Okay, that's fine. And then obviously we go opposite side and through. This can also, in this position, we can check for a stress fracture. So percussion tests, we go obviously to the greater trochanter. Any percussion there could be indicative of or indicate a femoral stress fracture. We'd also then go to the knee and percuffs, or we could go into an extended knee position and through. We can also then take a little bit of flexion in the knee, flexion in the hip, and apply a little bit more pressure down and through. So we're actually forcing through the longitudinal axis of the femur into the pelvis, into the hip socket, driving the head through into those points. Okay, so that's a lateral compression test. Now that takes us to. So face that way if you can, Will, please. Side lying. And again, we're on the pelvis, the iliac crest. We're coming across, and we're just applying compression through there. Usually 5-6 movements would be sufficient. Flip them over again onto your face the wall. And again, apply pressure down, making sure that there's no significant pain. Anything that's going to be damaged, soft tissue, connective tissue, even through the damage to the skeletal structure will be again provoked within that. Okay, so next thing we want to have a little look at is to make sure that we've got no labral tears, no labral pathologies. Now, there's 3 points, obviously through rectus femoris, psoas. We also then want to have a look at greater trochanter, but then we can also have a little look to see if there's anything more medially coming through the adductor group, gracilis, longus, magnus. Okay, so onto your back again. So what we're trying to do here is, initially, we can do a log roll test. So we're just looking to see if there's any pain brought on with those movements. Looking to internally, externally rotate log roll the hip complex. So that's your first test. The second stage of that is we're still trying to internally, externally rotate, but we combine it with flexion and extension. And anything again, pain-wise, taking it down into a little bit more flexion. Could pinch, could trap a loose body. Obviously looking to see if there's any significant pain. Change different ranges, internal, external rotation, and through and across. So any patient, any client who's complained of any anterior pain could be psoas, could be rectus femoris. And then if the sensation on the lateral aspect, it could be indicative of a greater trochanter, possible impingement, or again, as we said, through a snapping hip. If we suspect that it is rectus femoris, we can work through a Thomas test. Now a Thomas test is if we bring the knee to the chest, both hands onto the knee there, Will, please, and head flat, nice and flat back. We're taking the pelvis in the neutral position, and then the opposite, the contralateral leg will raise off the couch. This could indicate that we've got a hip flexor tightness. We can then also, in a modified position, so if you just take a stand down the end of the couch there, if you will. Okay, I'm going to put you up ever so slightly. Okay, modified position, so knee to your chest. Perfect. I'm just going to rock Will back onto the couch, nice and supported, full weight with me. Okay, so head flat back, shoulders try and maintain position. And then what we're trying to do is get it into as neutral position as possible. And we do have tight hip flexor there, so that's a modified Thomas Kendall's test. We can also then take the knee into flexion, externally rotate ever so slightly, let that see, and we can then assess for the end range within that position. It can also indicate if the leg is in straight position, possible distal hamstring tightness, or tightness into the head of the gastric muscle. Perfect. And then obviously we'll swap over, we'll assess both sides, and then we can see there how that is elevated up. End feel should be spongy, nothing too bad. Also that could be that could bring pain on, that could be indicative of some sort of possible issue, again with sacroiliac at the back if there's pain, pubic symphysis at the front in the groin position, or again, as we said, rectus femoris, psoas. Okay, come back up to me. Okay, then the last little thing that I want to do is to have a little look at, the last little thing that I want to have a look at is just the range of motion of the hamstrings. So go for that back here for me. Again, if there's been any complaint of any possible tightness, a good way to test for the hamstrings is to get it nice and flexed into the hip position, and then we just have a little look again to see if there's any significant deficiency or discrepancy in the length and through. And the left one is slightly tighter than the right. So that's Gainsland's, that's femoral shear, a lateral compression test. We've done a Thomas and a Kendall's test. We've done some gait, some posture. So that should wrap it up. Thank you.